Hi everyone, I want to talk about fibroids. Fibroids. Have you heard about that before? Or you yourself had it, or someone close to you? Okay, let's go. Fibroid is variously called Leiomyomas, Myomas, or commonly fibroids. It's the most common pelvic tumor in women. 40 to 50% of pre-menopausal women older than 35 years old are at risk. More in blacks and African Americans if you are talking of United States. They occur at earlier age in Africans and larger in size. Let me explain further on that. If a white lady and a black lady should develop fibroid the same day, the same hour, and they are in the same age group, it's going to be larger in size in the black lady compared to the white lady. It's mostly benign, meaning not malignant most of the times, so the fear of metastasis or killing you is down compared to many other cancers. But a fraction of it will become malignant, and that is about 1 in 1,000. Menopausal stage is an advantage. Why that? It regresses at this stage, but Leiomyosarcoma is also possible here. Size where you can find fibroid. It could be intramural, which means it's within the thick wall of the uterus itself. Or transmural, that is when it's occurring from the surface outside serosa and is passing through the entire thickness of the uterine wall and coming out at the inner part, that is the cavity of the uterus, called mucosa. It could be submucosal when it's occurring at the lining of the uterine cavity. Maybe serosa at the serosal surface around the broad ligament, and could become pedunculated at its base there on top of the serosa. It might be even coming down to the level of the cervix, called cervical myomas. And sometimes when it is submucosa, it could have stalk called pedunculated submucosa. The advantage of this pedunculated subserosa or pedunculated submucosa is that during surgery, it is easy to get them out. Genetics. Familial predisposition. It runs in families. So ask your mom, your aunt, your sisters, and so on and so forth. Pregnancies. The earlier the first pregnancy, or the higher the number of times that a woman is pregnant, the lower the risk of fibroid. Let me explain further here. That is why it should be not surprising when black ladies that are very cumbered with academic pursuit may not ever be married or have pregnancy until they are 25 and 30 years old, and they come down with fibroid, particularly if it is running in family also. The reason why most Reverend sisters who will never be pregnant or marry and they are blacks are having fibroid. But the same cannot be said about any pregnant lady for 1 or 2 months and they abort, depending on the number of times they engage in that. They can't match themselves with the chaste, non-pregnant, no abortion ladies at 25 and 30, and they are now coming down with fibroid. So I don't want to be disrespectful. Nobody should use this as a yardstick to say, oh, I'm not married and I'm not having fibroid. You're not married, you are a Reverend sister and you're having fibroid. There's a difference. The Reverend sister who has never been pregnant and not married and is black, standing the chances of having fibroid. Compared to those who are truly not married, but they've had pregnancies many times and they have aborted many times, they may not have fibroid because of the exposure to progesterone during the time they were pregnant and aborting, as the case may be. Early menarche increases the risk, while late menopause will also increase the risk because the uterus is subjected to estrogen for a long period of time. Combined oral contraceptives with high estrogen level will increase the risk, while progesterone only, like depot-medroxyprogesterone, will decrease the risk. In other words, if you are a black lady and you are 25 and above and you've not come down with fibroid and you want to have contraception, why not progesterone only? Discuss with your doctor, let him rule out and rule in whatever in you, then you embark on that. When it comes to race, I've said it earlier, it's more in blacks than whites. Prenatal exposure to testosterone increases the probability later in life. Obesity, for the same reason that obesity will lead to high cholesterol level, and high cholesterol level will be an advantage for more production of estrogen, then the chances of coming down with fibroid is higher in obese black young lady who is not pregnant. Still on risk factors. Alcohol increases the risk. Don't know why you'll be boozing, but you got to stop it now. Hypertension. Smoking actually reduces the risk. Well, to be honest with you, this is the first time I will know about this very fact, that smoking reduces the risk. I got this while searching the literatures on this, but the fact is I'm not going to promote smoking here because of this. There are other associated risk factors that you need to deal with. So don't go out right now, start smoking because you heard it from me today. No. It's a fact that some people have worked upon, but I am advocating for smoking cessation. Type 2 diabetes mellitus is going to decrease the risk. There is the joke. Do you want to have type 2 diabetes mellitus so that your risk of having fibroid will be reduced? I want someone to give me an answer at that end. Okay, nobody is smiling. Okay. It is not a good thing, but to those who have type 2 diabetes mellitus, the chances of having fibroid will drop. What are the clinical features? Most times it is asymptomatic. And when there are symptoms, it's going to be uterine bleeding that is going to be abnormal. Painful menses called dysmenorrhea, heavy cyclical menses, and intermenstrual bleeding. That is bleeding between the menstrual cycle. Also, there's possibility of pressure effect when the fibroid is very big. The pelvic region will become heavy and your abdomen will protrude, and some will even think that you're pregnant. There's possibility of urinary frequency when it's present on the bladder. The bladder cannot retain urine to its full capacity anymore. And urinary retention is a possibility with constipation if it's present on the colon. Fibroid degeneration will lead to pain, and the other time I said it could be pedunculated submucosal or pedunculated subserosal, and that would be an advantage during surgery. But here's the problem. The pedunculated type could have torsion, and when that happens, there'll be pain. Infertility because of recurrent pregnancy loss or miscarriage, which is spontaneous abortion in medical field. Well, why that? Intramural type, and when I was talking about signs, I'll explain that. And the submucosal type lining the cavity will make it difficult for blastocyst implantation and retention therein. And of course, rare degeneration during pregnancy will lead to very serious pain. I've seen few cases like that in the past. Obstructed labor, particularly if the fibroid is located along the passage of the passenger along the bed canal. Difficulty cesarean section for the same reason, and dyspareunia, painful relationship. Still on clinical features. It's possible that fibroid could prolapse. When that happens, through the speculum, you can see a large mass down there, and it could become painful and bleeding. But because it is now down, close down there where there are natural flora, it could become infected at the cervical region. Polycythemia is possible here. My MD will remember that we found a case like that in those days when a middle-aged woman was being prepared for surgery, and we took the complete blood count, and lo and behold, the PCV was still high. So fibroid has autonomous erythropoietin production, despite the fact that the woman was bleeding massively during the cyclical periods and intermenstrual spotting, yet the red blood cell count remain high. Hypercalcemia, autonomous production, or parathyroid hormone-related protein increase. Hyperprolactinemia is possible, but I can bet this may lead to infertility in the woman because there is possibility of negative feedback to the hypothalamic pituitary ovarian axis, and FSH, LH level will not surge. Investigations. Physical examination of the uterus and pelvis will give a clue. In fact, the abdominal gland size might raise the concern, and you have a clue, but you might not be able to say specifically that it's fibroid or not, but you know there's a mass there. Magnetic resonance imaging before surgery. Ultrasound is very useful here. Endometrial biopsy if older than 40 years old, but you are doing that to rule out endometrial carcinoma. Complete blood counts to know whether there's anemia here, but remember, there's possibility of polycythemia in some affected women. INR and PTT for the purpose of surgery and to also know whether or not this bleeding is only as a result of fibroid or there is a bleeding disorder in these women. And some will go as far as doing complete clotting profile, and some will do liver function test. Renal function tests and beta-human chorionic gonadotropin, because it is wise to rule out pregnancy when handling any woman of childbearing age. Treatment. Okay, what are you going to do? The diagnosis is made. It is fibroid. Confirmed. All right? It depends. The first thing to do is watch and wait if there are no symptoms. You can also watch and wait if the size is just 6 centimeters or below. Just watch. If the size is stable, you saw the woman 6 months ago and today the scan is giving you the same size, just continue to wait. And there's no symptom, she's not disturbed, then wait. Pregnancy. This is a patient. She's having fibroid, but fortunately for her, she's pregnant now. Just wait. Psychotherapy could be administered anyway while waiting, because some might become depressed. Particularly a pregnant woman with fibroid, there's serious pain. We'll talk about that in a bit. Medically, what are we going to give? Medical intervention is not meant to cure the fibroid, but to prevent it from going, from bad to worse. Antiprostaglandins, like any of the non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, diclofenac, will help. Tranexamic acid if there's massive bleeding, and oral contraceptive pill or depo-provera because they contain progestin, and we don't want anything that contains estradiol or estrogen. Gonadotropin releasing hormone agonists like leuprolide will help. Ulipristal acetate given 5 mg daily for 3 months is to prepare the woman for surgery, not to cure, because that is a form of neoadjuvant therapy to reduce the size of the tumor before operation. Radiologically, many centers in advanced countries are now practicing uterine artery embolization. That will shrink the fibroid by 50% within 6 months. Surgery. Surgery is definitive. Myomectomy could be done hysteroscopically through the abdomen, that is transabdominal, or laparoscopically. So just that portion that will be taken off with fibro, and then suture the remaining part together, and the woman can become pregnant after. Hysterectomy will be the best, but for those who still want to have pregnancy and raise family, no. But if a woman, like as a case we handled at my center in the past, woman who was not ready to have more children but still going from one hospital to the other, one doctor to the other, spending money, passing through pain, and I asked, why not hysterectomy? Do you still want to give birth to new baby? She said no. Okay. At that time, our last baby was 12 years old. So I discussed with my MD. We talked to her. She agreed. She had hysterectomy done. Today she's bouncing. So don't subject yourself to unnecessary stress, pain, agony, bleeding, depression. Once you are done raising your kids, you can get the uterus out and you're done with fibroid for life. Submucosal fibroid should be operated upon, particularly if woman would like to raise kids. Hysteroscopic resection of fibroids and endometrial ablation if there is abnormal uterine bleeding. Fibroid and pregnancy. Okay, why will I bring this up separately? Because there's what we call red degeneration during pregnancy as far as fibroid is concerned. Pain medication will be needed here. The woman will be in serious pain. Never operate in pregnancy. It can lead to pregnancy loss. The woman may head to court after. She may not thank you. Differential diagnosis. This could be pregnancy. The only thing we can do is rule out pregnancy here. This could be adenomyosis, or it has become malignant Leiomyosarcoma. This might be hematometria, that is blood within the uterine cavity. Just work out the diagnosis and be sure it's none of this before making the diagnosis. In conclusion, fibroid is less dangerous. Watch out for other cancers in women. I have published presentation on breast cancer, 4 of them. Everything on breast cancer is online right now. So check out for total VCAMS, breast cancer 1, 2, 3, 4. Thank you for watching. I'm going to publish endometrial carcinoma very soon. Kindly subscribe so that you can get these publications immediately they are released. Thank you, I appreciate it.